All right, welcome to our very last developmental stage, late adulthood, which is ages 60 and up. And as we've alluded to in the class already, we have more people reaching this age than ever before, who are generally healthier and more physically and cognitively capable than ever before. And the older adult or late adult population is, as a ratio, kind of growing worldwide due to this rising life expectancy and also those declining birth rates.
Okay, so we're going to start off this lecture material just talking about ageism, something that I am guilty of. I've been known, for example, to walk into a neighborhood party, look around, see a bunch of people with gray hair and internally think this isn't going to be any fun. And I've been having to challenge myself on those beliefs. In general, collectivist cultures have had more favorable views of older adults. So whether that's Asian, Latin American, African, and then those communities within the United States as well, for example, more respectful, more kind of valuing older adults. We are trying to become more favorable in the United States and other Western cultures. A really great TED Talk, and so I'd encourage you to carve out some time to watch it. Okay, so in terms of what ageism is, the most common forms are the first kind of the social or physical assumptions that we make, maybe assuming that someone won't be able to do something physically, assuming that they're not going to be fun or interesting, like me going to a party. My mom, for example, has been upset in going to the doctor's office with some of the questions she gets asked. And this happens because once you, I think, turn 65 or on Medicare, they're required to ask you a couple of questions. One, when you get there, is did you drive yourself here? Because they're trying to determine whether or not they need to arrange a ride for you. And my mom was horrified, like, what do you mean, did I drive myself here? And then the second question is, once you're in the exam room, they'll ask you, have you fallen recently? And she's like, why would you think I have fallen recently, right? So those would be some of those physical assumptions. Now, in this case, they're required by Medicare, but those kinds of assumptions might fall under ageism. It could also be assuming that they need your help when they actually don't. Or, of course, a lack of respect. So my mom noticed that when she and I traveled together internationally, people in the service industry often just talked to me and almost treated her like she was invisible. And of course, these can be just benevolent, like you don't even realize that you're not looking at the older person sitting at the table when you're the server, or obviously it can be more hostile. You're yelling, you crazy old man at your car window. These can be coming from your family members, or they can be complete strangers. Ageism is considered the most socially acceptable ism. It's more common than sexism and racism in many countries. And of course, like all isms, that has that intersectionality. So it's going to be more challenging the more isms you are experiencing. So if you're both a woman and older and a person of color, for example, and with a disability, then you're going to have a number of isms, overlapping. Interestingly, this is the one ism against a changing rather than stable subpopulation. So if we live long enough, we're all going to be old, whereas most of us aren't changing the color of our skin over time, or changing our sex, less common. So this is an experience where we have a bias against a population that's shifting and which we will eventually become. We don't always challenge our own ageist views like we might our sexist or racist views. They're often just internalized. We're exposed to kind of views of aging through TV shows we watch, movies, our family, what we see around us. And so obviously how ageist we are varies based on what we've been exposed to. Interestingly, research has found that the more negative stereotypes that we hold when we're younger are actually correlated with poorer cognitive and physical decline as we age. So to put that into more simple terms, the more I think negatively at my age, in middle adulthood, of people in older adulthood, the more likely I am to have problems, specifically hearing decline, poorer health, and performance when I get older. So this research finding has been kind of motivation for me to check myself and be thinking of older adults in a more positive way, because I'm soon going to be one.
So one way that we can counter ageism is to think of someone who's over 60 and really think about what we have learned from them or can learn from them, or what we appreciate about them, or perhaps even a quality that we want to emulate or copy. So because late adulthood can potentially be, 30 or 40 years, it's divided into substages. So the young old is the first 15 years, 60 to 74. The old, which is the middle years, middle decade of 75 to 84, and then the oldest old, which is 85 plus. And generally each stage is kind of qualitatively different regarding physical, cognitive, and social functioning. So on average, that if you just put people into these groups, they look different in terms of kind of how well they're functioning. My parents, who are right now young old in their early 70s, call these stages the go-go years, the slow-go years, and the no-go years. And so sometimes I'll ask my dad, like, are you going to work on your rose garden again? And he'll say to me, no, we're in the go-go years. We're traveling, we're going, we don't want to be tied down. Rose gardens are for the slow-go years. Or I'll say, are you going to get a dog? He's like, that's slow-go or no-go, So different ways to think about these substages. Okay, so the ways that the substages of late adulthood that we just talked about differ is in terms of your ability to perform activities of daily living, which are also called ADLs. And so if you work, for example, with older adults, you've heard this term. So there are basic ADLs and then more advanced or instrumental ADLs. So basic ADLs are things like eating, bathing, dressing, toileting, being able to be continent, getting out of a bed or a car or bed or a chair by yourself, and walking even with the aid of a cane or a walker. Instrumental activities of daily living, which are more advanced, are things like food preparation, house cleaning, laundry, managing finances, doing your own grocery shopping, taking your own medication, being responsible for your own transportation, managing technology. And you can see from this graph here that there's variability by country in what the level of impairment in ADLs is in late adulthood. And this probably has to do with the kind of economic status of the country, and also kind of the overall health behaviors, throughout life that have maybe accumulated in terms of secondary aging experiences. And so sometimes we talk about people's functional age versus their chronological age. So a person's chronological age might be 75, but they might be doing really well, and having the functioning more of a 69-year-old, or they might seem to be not doing so well and have the functioning of, an 82-year-old. My mom is always thrilled when she goes to her doctor and her doctor says something like, you have the physical functioning of someone in their early 60s. And she's like, yay, because she's in her early 70s, right? So it's all relative. So as we've talked about, our oldest generations are now living longer due to better medical care. And we have a smaller ratio of those in the younger generation due to a lower total fertility rate and lower births. And so what this means is that we have what's called the rising old age dependency ratio, or OADR, where the number of persons over the age of 65 is growing, and the number of persons aged 20 to 64, basically the workers who could be financially supporting them, is shrinking. And so what this means is that there's more pressure on the working adult population to support an older adult population. And so this can be in the form of paying into Social Security or Medicare here in the United States, but it could also be in countries without, pensions or systems like that, they are just directly relying more on their children or grandchildren for financial support. And you can see that this is more of an issue in places like Japan or Germany that have a low birth rate but very good medical care for an older adult population. A little less of an issue for the United States because we have a higher immigrant population, both with documentation and without documentation, and immigrants come in younger typically. People immigrate when they're younger, not in late adulthood. Okay, so around the world we see a specific pattern related to gender and aging, where women are living on average about 5 years longer than men. And this is both due to genetic and environmental reasons. So genetically, you remember at the beginning of the semester we talked about X-linked inheritance, and that due to the smaller Y chromosome, males are more likely to manifest recessive genetic disorders on the X, on their X, since they don't have another X to counter it out. And it's also environmental. Men are more likely to engage in riskier behaviors and poorer health behaviors throughout their lives. So men are more likely to smoke and drink more than women on average. So we really see this. We see this throughout all substages of older adulthood, but once we get to that third substage, the oldest old, it's a ratio of more than 2 to 1. So in the United States, above the age of 85, there's 226 women for every 100 men. So my grandfather was single because my grandmother died in her mid-60s, and so he was tall and thin and in good health, had a full head of silver hair, and he was dating 3 women at the same time because he was such a hot commodity. So what I often say is, if you're a straight male and you can make it to late adulthood, you could be really in high demand. Okay, so let's get more into physical development in late adulthood, where I have to tell you the news isn't so good. It's pretty much, if we were rating physical development, we're going to give it a thumbs down in late adulthood.
Not surprisingly, how we age, how well we age, depends a lot on money. And so people who have less money and people of color in the United States and in Colorado specifically have poorer health outcomes in general, and for mental health and even for dental health. And we're currently seeing a widening gap. Basically, people who are older adults with more money are doing better than ever before, but people who have less money are doing, worse. Their line is going in the other direction.
So by the time we hit our 60s, we're seeing more dramatic changes in physical appearance, regardless of how well you've been trying to take care of yourself. Graying and thinning hair showing up in all the places you don't want it to, coming out of your nose, on your chin, coming out of your ears, seeing more of those age spots, those darker spots, and also white spots where the pigment has disappeared in your skin. Height and weight generally decline because you're losing muscle mass and also bone mass and cartilage, which is kind of, things are kind of shrinking. So my dad was once proudly, 6'2", but now he's more like 6 feet. Your teeth yellow as a result of just aging in general, and a result of, coffee and tea. Your face tends to thin or atrophy because you've lost kind of the fat underneath your skin. You may have heard the statement that people's noses and ears, the cartilage continues to grow as you age, and that's why older people have such big noses and ears. When I've gone looking in the research, I've not been able to find evidence of that. That it says that kind of the mass of ears and noses stay the same, but they droop more, and because the face is shrinking and then your ears and nose are drooping, they appear bigger. I still have a hard time believing that because it seems like older people can have really big noses and ears, but that's what the research says. Okay, so let's talk about some changes in the senses that have become really pronounced in late adulthood, especially as we get further along. So vision, we already talked about increasing kind of farsightedness, having trouble reading things up close, more need for glasses, readers, bifocals. Also, older adults can be experiencing cataracts, which is the thickening of the lens of the eye. It gets kind of cloudy and distorted, and so then people are often having cataract surgery once it gets bad enough. It's the most common visual impairment. You also have an increased chance of macular degeneration, which is damage to the retina, where then you're having less central vision. And you can have increased chance of glaucoma, which is fluid in the eye that pressures the optic nerve and gives you less peripheral vision. Hearing, I encourage you to watch the Saturday Night Live Amazon Echo Silver skit. My kids and I have watched this probably half a dozen times and still find it hysterical. So if you've got a minute, it's definitely worth watching. Once you get into the old, so which is 75 and up, about 75% of the old, that's the middle substage, are showing some hearing impairments. And many people with hearing impairments are still resisting wearing hearing aids, and you might have loved ones, who are demonstrating this. This can be for various reasons. One, they can be a pain to put in and take out, and you might think, oh, I don't really need them, or I'm not going to need them most of the day. You can often forget where you've placed them. The good tiny hearing aids are really expensive. It can be hard maybe to adjust the volume on them as you're moving from kind of loud to quieter situations. And so what that means is that if you're not hearing as well, you have increased social isolation. And so you may have noticed with your older adult relatives that they sometimes seem to jump into a conversation in a disjointed way. So I noticed this with my grandpa. We'd all be sitting around a dinner table over the holidays with a bunch of people talking, and I don't think he could hear well enough to track the conversation, and so he would just interrupt with some kind of random story, right? Because he wanted to contribute and engage, but he couldn't pick up on the general conversation. Taste and smell also decline, and so food becomes kind of less enjoyable. You can still taste the 4 basic flavors that you learned about in infancy: sweet, sour, bitter, and salty, but they just you can't taste them as well. Food seems blander, you're secreting less saliva. And so what that means is that you might not know that food has gone bad. And so many of you might be the ones who go with your family members to older relatives' house and like clean out the fridge, right? Because they don't realize that so much of the food has gone bad. And then skin isn't up there in terms of touch, but the skin of elderly adults becomes kind of less responsive to heat and cold, and so they struggle more to regulate body temperature. Okay, so you remember back when we were learning about infancy and toddlerhood and preschool and all the gains in gross motor abilities and fine motor control, and now we're seeing declines. And so older adults have a reduction in stamina, in their physical dexterity and coordination, and in their balance. And once you lose balance, then you're more at higher risk of falling and breaking a hip and going into the hospital and then contracting something else that can put you kind of on this downward spiral. For fine motor, for example, it's harder to manage a computer mouse or to button things or to open prescription pill containers or to thread needles. You might notice from your older adults in their handwriting that it gets, more shaky, for example. So all the same health issues that we talked about in young and middle adulthood still apply, risks for cancer and heart disease. But we'll highlight a few others here. So sleep apnea, something that you may have loved ones who have been diagnosed with. So in general, your quality of sleep declines with age. You're pretty much starting to wake up at the time you practically went to bed when you were in college. And you're also sleeping less deeply. Your time in light sleep increases. And so then sleep apnea can also be a common sleep problem. This is where your breathing stops for 10 or more seconds during the night. And this can be treated with a CPAP device, which stands for continuous positive airway pressure. And so you may have loved ones kind of sleeping with these. They also have the nice added benefit of preventing snoring. It's not actually like being on oxygen. It basically just is a tube that kind of forces, doesn't go down your throat, but it's just a mask that forces air into the back of your throat so that you have to kind of keep breathing. You can't stop breathing. And sleep apnea treatment can be very effective in helping you feel more alert during the day, and so less likely to be kind of falling asleep. Can improve cognitive functioning, and now is being kind of correlated with reduced risk of dementia. And we'll talk more about that when we get to dementia. Other things like health issues and medications can also impair sleep. Psychological issues can impair sleep, so depression, anxiety, bladder issues. All right, so then arthritis is the disease of the joints. It's when the cartilage that cushions the joints wear out. About half of adults over age 65 in developed countries show some arthritis. Women more than men. Management often involves kind of medication, or you can have things like knee replacement, hip replacement, and also, exercises. Osteoporosis we talked about, which is increased thinning of the bone. Exercise and calcium kind of earlier in life are best for kind of strengthening bones. Your risk for osteoporosis really rises with age. By 90, about 70% of women have it. We talked about in middle adulthood how also hormone replacement therapy can reduce the rates of osteoporosis. It does occur in men as well. And then hypertension or high blood pressure, about 70% of adults over 65 have it. Your heart is becoming less efficient and basically has to work harder to pump blood through the blood vessels. So it can be a primary aging factor, but secondary aging can worsen it, like your diet, not exercising, smoking, or certain medications. Okay, so you may have wondered, why is it that we age? Why can't we just live forever? Why does our body start to shut down? And there's a number of factors, but many of the cells in our body seem to show what's called the Hayflick limit, which is basically the cellular clock that limits the amount of times cells can replicate themselves. So maybe after about 50 times, which is known as the Hayflick limit, cells can't keep dividing. And this is associated with the telomeres, which are the end caps on chromosomes, kind of like the little caps that are on your shoelaces, right? And if they get too short, then the ends of the chromosomes kind of get too frayed and the cell can't keep replicating itself. So that's one factor, and we will be talking about kind of how we can lengthen telomeres. They don't just go away, they can actually get longer. And then free radicals also damage cells and increase the risk of disease, and we'll talk about that on the next slide, which is why we see such emphasis on antioxidants. Okay, so a free radical is basically an unstable unit in the body, an atom or a molecule that has an unpaired electron in the outer shell that's causing basically oxidative damage to the body. And so then antioxidants take on the extra electrons and help reduce the damage of free radicals. And so that's why we hear all this about blueberries are, antioxidant, or this is antioxidant, or you can take, antioxidants. And I think what the research would say is that so far taking supplemental antioxidants is questionable, but getting antioxidants in your food, your fruits and vegetables, is really important for preventing kind of cellular damage or reducing cellular damage. Okay, so what research says is that stress can shorten our telomeres, probably through kind of inflammation and oxidative stress. Parents of kids with disabilities, on average, have shorter telomeres in some research studies. But then the good news is that support can also lengthen or grow our telomeres. And so research on women diagnosed with cervical cancer who receive kind of supportive counseling show that their telomeres can actually be longer as a result of that counseling. Other research on physical activity says the more physical exercise that you engaged in, especially if we're targeting ages 40 to 64, the less likely you are to have shorter telomeres. And it seems to be dose responsive. So a little bit of exercise means, slightly less shortening. A lot of exercise means more kind of lengthening, I guess I should say, of the telomeres. Okay, let's switch gears and talk about cognitive development in late adulthood. And in general, if we think about functioning overall, this is again a thumbs down. Cognitive development is generally declining in late adulthood. So all of those gains that we saw for kids in terms of attention and memory, now we're starting to see them decline again. So selective attention, the ability to focus in on something, your ability to do that declines. Your ability to divide your attention or multitask declines, and your ability to keep your attention kind of sustained at a task also declines. Older adults see declines in working memory, so they can't, on those kinds of digit tasks or try to remember as many of these things as you can in a short period of time and then recall them. Those kinds of memory tests older adults don't do as well. Autobiographical memory is, remembering about your own life, and you might think that older adults are really awesome at this because they always are telling stories, right, about their lives. Yet it's selective. In general, people are the best at recalling ages 10 through 30, and then the most recent decade and key life events, but not all of their life. There's also declines in source memory, which is knowing where you learned something. And I can feel this happening to me already, where you've heard it, but you can't remember where you learned it. There's interestingly declines in your ability to remember unpleasant things, and that's called the positivity effect, where you're more likely to remember things that were pleasant and forget things that were unpleasant. And then older adults show very little decline in procedural or semantic memory. Procedural is more implicit memory. It's how you do things. So you can remember, even if you might not be able to ride a bike as well, you can remember how to ride a bike. You can remember how to put on your clothes. You can remember how to make food, kind of all those things that you normally do. And also semantic memory is vocabulary and facts. And there's very little decline in that, which is why your older adult relatives can still kick your butt in Scrabble or other word games. So now we're seeing all the declines in brain functioning, brain mass, myelination, neurons, and neurotransmitters are all declining as we age. The two brain images on this slide are of a 27-year-old brain and an 87-year-old brain. And so you can see that the spaces within the brain increase. For example, in areas associated with memory, in the cerebellum associated with kind of movement, and in the frontal lobes, associated with planning, attention, memory. We also know that myelination begins to decline, so the glial cells that make up myelin begin to wither, and then the synaptic connections become less efficient, and then reaction time increases for everyday tasks as synaptic speed slows. We also lose neurons as we age. It's unclear how critical those always are for functioning because neurons are dying and birthing constantly, but at this age you have more dying than being born. Neurotransmitters like dopamine also decline, and so that maybe contributes to the lack of effective kind of mental processing. And brains on average are just less plastic. Your brain will maintain some plasticity, right? You can still learn new things as you get older, but it's harder to do that. Between the ages of 60 and 90, adults with higher levels of education show less atrophy or shrinking of the cerebral cortex. And we also know that physical and cognitive activity reduce declines. Here's also an example of how diet and nutrition can affect the brain. So you may have heard about the Mediterranean diet. It's kind of a diet that might come from southern Italy or Greece. It's a diet that's high in veggies, fruits, olive oil, whole grains, moderate amounts of protein and dairy fat. And in general, it's had good correlations with physical health, diabetes, heart, and stroke, but now there's more increasing research that says it's also good for brain health. So here's the details of that study on the Mediterranean diet in the brain. It was a longitudinal study involving over 5,000 Scottish older adults, so people in their mid-70s. And the more they consumed kind of the Mediterranean diet, the less brain atrophy they showed. It didn't seem to be related to specific types of meat or fish. So it might be other aspects of the Mediterranean diet, fruits, vegetables, olive oil, nuts, things like that. But the conclusion is that basically adhering to a Mediterranean diet might reduce brain shrinkage. This is a research study that compared young and older adults on levels of fitness and then performance on executive functioning and memory tests. And so what you can see there is that executive functioning seems to be more responsive to exercise. So exercise has kind of a more powerful role in predicting your executive functioning, as high-fit older adults perform just as well as young adults on executive functioning tasks. So maybe setting goals, monitoring your progress, things like that. But when we look at memory, some other types of memory tasks, exercise can help older adults perform better than people their age who are less fit, but it still can't counteract the effects of age, and young adults, regardless of their fitness, could perform better than you. But we do know that, like we talked about with kids, aerobic exercise seems to be correlated with bigger kind of hippocampal volume, and those generally, your hippocampi are associated with memory, as we've talked about, and they tend to shrink with age. So having aerobic functioning kind of offsets that and prevents the loss of volume in the hippocampi. So let's talk more about Alzheimer's and dementia. So we often use the term Alzheimer's as synonymous with dementia, but Alzheimer's is just the most common form of dementia, and there's over 70 different kinds. But about 5.5 million people in the United States are diagnosed with Alzheimer's. And Alzheimer's is associated with two brain features in particular: amyloid proteins, which result in amyloid plaques, which are deposits in the brain that kind of clump up in between neurons and interfere with synapses, and then also accumulations of tau protein, which show up in neurofibrillary tangles within neurons that cause kind of bundled of fibers within the neurons and keep them from functioning well. There's a lot of research happening on Alzheimer's and dementia right now, and some of the risk factors are both genetic and environmental. So the APO gene, for example, is a gene for amyloid protein, and it puts you at risk, but not all people with the gene actually develop Alzheimer's. So the variant is found in about 15% of the population in general, and about 50% of Alzheimer's patients. Male carriers of this gene are only a little bit more likely to develop the disease, but female carriers, it increases your chances to almost double. So it can vary based on gender as well as the gene. Having less kind of cognitive activity or ability in general, and poor physical health. So conditions such as diabetes, hypertension, and obesity or overweight in midlife are associated with 2 to 3.5 times greater of developing Alzheimer's disease or dementia. Also, sleep apnea and short sleeping are correlated with increased risk of dementia. And research on this is emerging, but what we are thinking happens is that there's something called the glymphatic system in the brain, kind of like the lymphatic system, that while you are sleeping at night, it basically washes out the amyloid plaques from the brain, kind of removes the buildup. So if you aren't sleeping well due to sleep apnea or other things, then you're not getting those plaques washed out, and then you're more likely to develop dementia. So then, of course, getting good sleep is a protective factor. We already talked about exercise as protective. definitely research that's showing kind of learning new things, keeping your brain active, and the Mediterranean diet again is associated with decreased risk of dementia. And so people, just a quick word about caregiving. Lots of people end up caregiving, including maybe some of you, because increased numbers of emerging and young adults are caregivers for older adults with middle or older adults with dementia. And a term that is really helpful in understanding this experience is ambiguous loss, which is that you are often grieving your loved one before they've actually died, because their ability to be kind of psychologically present in who they are is already waning, and so you're already maybe grieving your grandmother or your father, even though they're still alive, because they're not who they used to be. So we've been trying to develop tests for Alzheimer's that are can kind of help us in early diagnosis. Our current methods are more involved and more expensive. You know, it's using spinal taps, PET or brain scans, PET scans or MRI scans to look for the amyloid or tau kind of proteins or things that indicate their presence. And so those are generally less comfortable and tend to be more expensive. And so we're trying to kind of have more widespread blood tests that can measure the amyloid protein, possibly the tau protein. And we have those, and we're just working on trying to get them to be sensitive and reliable enough. Right now, their accuracy is about 85 to 90% of the time, and in order to be really widely used, they need to be almost perfect predictors of Alzheimer's. In the absence of easy tests for early onset or early signs of dementia, we are seeing kind of researchers show some other early signs. So having a poor sense of smells, there's a number of studies that have kind of come out around that, where they're putting people through smell tests, and the less well that you can detect smells like peanut butter or orange or leather or peppermint or fish, or you can smell it better from one side of the nose but not from the other side, especially if the left side of the brain is more deteriorated, then you won't be able to smell as much through your left nostril. And so that is kind of an earlier predictor of dementia. Changes in sleeping patterns. So once people suddenly start sleeping more than 9 hours a night, but hadn't slept so much previously, that's more of a risk of developing dementia. People we talked about with untreated sleep apnea. So that would be an early warning sign. Also just showing more irritability, aggressiveness, depression. And of course, the things that we think about, the mild cognitive impairment. So showing declines in memory, executive functioning, language, paying attention. And of course, that's happening already as we age, but it becomes more pronounced if we are experiencing dementia. And then, of course, mood or behavioral changes. If we take two people and they both have mild cognitive impairment, then the one with mood or behavioral changes develops full-blown dementia faster. So having, for example, depressive symptoms is an increased risk factor of developing dementia. So one way that older adults deal with cognitive declines is what's called selective optimization with compensation, or SOC, and you can see what it stands for there. S, selecting valued activities, O, optimizing performances, and C, compensating by using new strategies. So instead of trying to do as much as they used to, older adults might pick things that are really important to them and focus on them and let other activities go. And then because they've kind of narrowed what they're focusing on, they have more time to kind of optimize it. So they could practice a musical performance more, or some skill, they can focus in on it more. And they can also compensate by kind of using new strategies. And so this is just basically, I think, a variation on experience and expertise. The more you've done something, the more you kind of realize how you can kind of cut corners, right? Maybe you don't have to get out the full recipe because it doesn't actually matter if you measure it that precisely. You've done it enough times, you can just kind of quickly judge the amounts, right? and so just the ways that you can use your expertise to kind of do things more quickly or efficiently. Okay, so let's transition into emotional and social development. So whereas the news on the physical and cognitive fronts was more negative, thumbs down, the news on average in emotional and social development tends to be more thumbs up, with some challenges, of course. Okay, so if we return to Erikson, in Erikson's final stage, we are trying to achieve ego integrity and to avoid despair, right? So we would like to feel like we've looked back on our lives and that we've had a meaningful life, that kind of the positives have outweighed the negatives. And maybe like you, I can remember a point in college where I decided that, it was one organizing principle of the way I wanted to live my life was that when it came to the end, that all of the positives would outweigh kind of the negative ways that I had impacted the world. Okay, so here's some good news. In older adulthood, you can see between the ages of 25 and 75, so this 50-year period, on average, positive affect tends to go up, especially once we get into middle age, and negative affect tends to go down. So once you kind of get out of those child-rearing years, maybe you've established yourself in your profession, you have more self-acceptance, you might have less stress, more kind of control over your life. But certainly we're going to be talking about some of the challenging things that can happen in adulthood. Death of a spouse, loneliness, physical health problems, early dementia, depression, suicidality. So it's not all, great. So this could be a reason why we see positive affect go up and negative affect or emotion go down is due to socio-emotional selectivity theory, that older adults basically maximize their emotional well-being by becoming increasingly selective or picky about who they spend time with socially. And so they basically start picking the situations that they enjoy being in, like your friends, your grandkids, the family members that you really enjoy. And they start decreasing the amount of time spent with people they don't enjoy. And they probably retired at this point, and so they're not having to maybe navigate problematic work relationships. So they are seeking relationships that are low in conflict and high in emotional, or kind of high in mutual enjoyment. So the graph just shows the increasing number of older adults in the United States needing care. And so this creates a caregiving dilemma that lots of families are trying to figure out. And most seniors, if asked, would prefer to stay in their own home. So some are getting that option, or maybe living with family members. And then there are two different types of care that are provided to older adults, and they could have one or both of these types of care, and they could be provided in any situation, in their own home, in family members' homes, or in an institution. So the first one is called non-skilled or custodial care, and this is basically helping with it. It does require skill, right, to do it, but it's helping with activities of daily living. So bathing, dressing, eating, and this is maybe things that home health aides or hired companions or CNAs, certified nursing assistants, might be doing. Custodial care is, typical care for many older seniors, especially those with any form of dementia. And then more skilled care is care that's provided by nurses, physical therapists, occupational therapists, physician's assistants, nurse practitioners. So basically requires a higher level of training. And this can also be provided in home or in a inpatient situation. So, and then when we think about kind of the level of care, when people can't maybe live all of the time in their own home or with family, then people might use adult daycare, where if you are, example, working, you take your mom there during the day so that it's kind of like childcare, but during the day where someone's kind of watching her while you're at work. And then we have different levels of residential care. We have independent living, which is oftentimes homes within a senior living complex that offer transportation, recreational activities, but not any health care services. And then we have assisted living, which is residents that provide help with activities of daily living, including basic health services, recreational and social activities, but generally not skilled nursing care. And then we've got skilled nursing homes, and this is where you're getting 24/7 care by licensed health professionals, and it can include all housekeeping, medical, and social needs. And then within those, we have memory care units for people with advanced dementia. And definitely not all nursing homes are equivalent in terms of quality of life and quality of care. It can be much harder, for example, to get high quality care in rural facilities on average than urban facilities. So let's pay some attention for a few slides to elder abuse, which is an area of growing concern. Something that research would say, since we started tracking it, has really increased over the last several decades. And this could be both because we have a higher awareness and also because we have more people living into old age and more people experiencing kind of the stress of caring for them and maybe kind of that sandwich generation phenomenon. It's something that is happening around the world that we're attending to, but there's just a lot of underreporting of the numbers, and so it's hard to get kind of real accurate statistics. You can see there from the U.S. Department of Justice, only 1 in every 23 cases actually gets reported to Adult Protective Services. We're estimating that 1 in 10 seniors is abused each year in the United States, and we'll talk about what that might look like. People who have been who are seniors who've experienced abuse are more at risk for death. People who are experiencing cognitive decline are more at risk for abuse, including financial abuse, and are people who are being abused are more likely to be placed in a nursing home as well. In the United States, we also see higher numbers of elder abuse happening for women, the oldest old, which is people over 85, and those with dementia. Okay, so it's important to note that 90% of elder abuse is perpetrated by family members. So this is much less likely to be happening, for example, in a nursing home, and much more likely to be happening within people's families. And so this can be certainly older adults who are more impaired, who are more dependent. So as those, for example, with dementia, those who have really poor health are more at risk for being abused, presumably because they're just more challenging to care for, and this leads to increased caregiver stress. So if you are a caregiver who is caring for an older adult, you are at higher risk to be abusive the more caregiver stress you have. And so if the person is really hard to care for, or you don't have kind of the skills or resources, this is more likely to put you at risk for perpetrating elder abuse or neglect. Also, if you have your own kind of substance abuse issue or mental health issue, that puts you more at risk. The more you perceive yourself to be burdened by this, which can be associated with how hard the person is to care for, along with your own external stress, things like financial problems, job stress. That's been demonstrated, with domestic violence and child maltreatment as well. And then, of course, social isolation. Abuse in any form is more likely to occur in families characterized by social isolation. And so it can be a contributing cause of abuse. So global data on the prevalence of specific types of elder abuse doesn't exist, and this is still the most current data I can get from 2006 on elder abuse in the United States. And so what you can see is that physical neglect or abandonment has the highest rate of forms of abuse, followed by legal or financial exploitation, emotional abuse, physical abuse, and then sexual abuse, which is very rare. And so most elder abuse involves self-neglect or abandonment, which is where the elder is allowed to basically neglect their own health or safety, and may not have good hygiene or good nutrition or have all their illnesses treated. And this may be because they're challenging to help, because you don't realize how bad things are, or because they are even refusing help. So I once in college worked as a house cleaner a couple of hours a week for an older woman who had had a traumatic brain injury. And she greeted me at the door, saying things like, my name is so-and-so, and my best friends are Mr. Smith and Mr. Wesson, and nobody messes with me. And she had a German Shepherd who luckily liked me, but didn't like a lot of other people. And so she was really hard for people to take care of. And in fact, when I was concerned about her and called social services, they said, we've been trying to send people out and she turns everybody away. And also she had a traumatic brain injury. She was difficult to communicate with. And I think her own family in town had kind of given up a little bit and let her kind of almost move into this very kind of self-neglected state. Physical abuse. So financial, is the next one. And we are hearing stories about that. Obviously there can be scams that people are subject to, but again, remember this is most likely family members, and so it can be family members kind of financially exploiting loved ones. And then the other forms, emotional, physical, and sexual abuse, are less common, but still occurring, of course, especially physical, we still need to attend to. So many laws started passing elder abuse reporting requirements, and so we did that here in Colorado in 2014. And so now, just like we mandate the reporting of child abuse and neglect, we also mandate the reporting of elder abuse and neglect. And so our next slide will tell us kind of who are the mandated reporters. But basically, if it's somebody over 70 and you have a risk, you suspect abuse or neglect, you're mandated to report within 24 hours of having kind of a reasonable suspicion of the abuse or neglect. And here in Larimer County, you can see the number that you would call, but this would vary, by state, what the state law was, and what the county procedures are. So just like with child maltreatment, we had a list. We have a similar list for older adults, and you can see some similarities in that, all health professionals and mental health professionals are mandated reporters, along with clergy members. But then also we have a whole set of basically, instead of daycare, we have home health care providers and volunteers, and then we have anybody kind of related to medication or financial institutions also being mandated reporters. Okay, so even with rising divorce rates in older adulthood, marital satisfaction tends to be at its peak. You're more likely to be married today longer than ever before due to living longer. Some reasons why marital satisfaction is at its peak is that people who were unhappy divorced earlier, so only the strongest kind of marriages are left. There's less kind of daily stress that kind of put a pressure on a relationship. There's more time to enjoy leisure activities. There's more kind of experience navigating kind of your perpetual conflict. So you've got the things that you always disagree on, and maybe you've just gotten better at accepting them or kind of talking through them. Sexual desire declines, but still persists for many. It depends upon the physical health of you and your partner. And interestingly, in assisted living facilities, sexually transmitted infection rates are increasing. And so this is becoming an issue where assisted living facilities are having to kind of navigate what's allowed in terms of sex and how do we kind of help older adults practice safe sex. If you experience the death of a spouse in older adulthood, that grief and depression can last for many years. It's not something that you kind of easily get over, not that we ever do with death. It can lead to increased health risks. So for sure in the first year following the death of a loved one, we see that people have higher rates of illness and accidents. Death of a spouse also increases your risk of loneliness, and it would be really normal to have a continuing bond with your spouse, to continue to talk to them, talk about them, keep pictures and things of them up, and have a sense of connection. Remarriage rates are fairly low at this age because of a couple of things. First is gender disparity. If the majority of older adults are heterosexual and we have very few men and a lot more women, then it's harder for people to remarry. And people also might not remarry because of finances. They're wanting to kind of keep finances simpler, or maybe their kids don't want them to remarry and kind of make more complicated financial and inheritance situations. And so we're seeing some increasing rates of cohabitation among older adults as well. Okay, so let's talk about something that's getting more attention in the media, which is loneliness or social isolation. And so this is measured in research studies by people living alone or having not as many social network, not reporting a very strong social network, or less social contact because perhaps many peers or family members have died, or you're not able to kind of get out and do as much. And so about 40% of adults over the age of 65 report being lonely at least sometimes. Loneliness puts you at risk for earlier death. So in a specific study of older adults in Amsterdam of about 3,000 individuals, loneliness significantly predicted mortality over a 3-year period, even controlling for things like age and disease and substance use and kind of functional limitations. Loneliness is correlated with various mental health issues, depression, decreased cognitive performance and increased cognitive decline, dementia, and so these things can become kind of cyclical, right? When you've got other things going on, you might not be able to have as much of a robust social network, then that kind of contributes to your cognitive decline and your poor mental health, and then that, of course, decreases your social interactions and increases your isolation. In terms of interventions for loneliness, some research investigated kind of a couple of different types of intervention. More group interventions where you bring seniors together, and these have been shown to be the most effective. So bringing together groups of women or caregivers or widows or widowers, and kind of helping them do group volunteering or educational workshops. Those have shown to be fairly effective in reducing loneliness and isolation. One-on-one interventions such as nurse visits or peer phone calls, while nice, haven't been found to be as effective in reducing social isolation and loneliness. Okay, so let's talk more about when depression leads to suicide. And so what you can see there is that suicide rates are the highest in late adulthood for men. In particular, this is white men. White Caucasian males in the United States show a much higher risk than Asian, Hispanic, or Black males. Black males actually have the lowest. So white males are about 3 times as likely to die by suicide compared to Black males. White males are about 2 times as likely compared to Hispanic males. And then Asian or Pacific Islander males are kind of in between white males and Hispanic males. And so this has been one of the factors that we think is about that loneliness or social isolation. And that some groups that have more of a collectivist mindset might have more kind of family protection and close relationships. Religion and kind of cultural tendencies might also play a role. So people have suggested a cultural tendency towards what's called fatalism, or expecting adversity, might actually help African Americans and Hispanic Americans kind of adapt to chronic stress. It's also perhaps a cultural thing. So some researchers who have talked with pastors at African American churches in the southern U.S. have said that they will say things like suicide is more of a white thing, and so Blacks don't have maybe a cultural sense that that's an option, and it seemed more like maybe a contradiction to the Black experience that has maybe developed a culture of resilience. Okay, so I'd encourage you to watch this video, maybe even just a little bit of it, showing kind of work and retirement across cultures and kind of what that looks like in the United States, but also around the world. And so what you'll see in the film is that in the United States, we have this idea that you can kind of retire while you're still active, or perhaps, and then, enrich your life in other ways. But of course, historically, and in many cultures around the world, you just work until you cannot physically work anymore. So here in the United States, the average age of retirement is in your early 60s, but it's affected by, what you can financially afford, how good your physical health is, so you'll retire earlier if you're having more health problems, and how much you're enjoying your job. About 25% of people who retire in the United States report kind of struggling, right? Having adjustment difficulties, maybe feeling depressed or lost, increased stress. And this is much more likely if you did not choose to retire, perhaps if you were laid off. So we do see more people kind of phasing out their work through part-time work. Sometimes it's called a bridge job, where you do something kind of in between, or kind of reduce what you're doing. And you're doing this maybe for financial reasons, yet also for structure. Yet there can also be problems in obtaining kind of part-time work because of stereotypes related to age and ageism. Okay, so let's talk last about leisure activities. So you may hear your loved ones talk about all the things they're going to do in retirement, and sometimes I think of those things too, like what are the things I didn't have time to do in my life that I'm going to do when I retire, whether that's a cooking class or a dancing class or learning a language or something like that. But what research says is people do some of that, but they also just spend more time doing the things that they already enjoyed prior to retirement. So if they like to garden, they garden more. If they like to travel, they travel more. If they like to watch TV, they do that more. If they like to do crafts, they do more of that. Television still tends to, or screen time still tend to compose like the majority of leisure time. So television, reading, movies, and music composes about 40% of leisure time. People also do more community service and civic engagement, and this is correlated with better kind of well-being and social connections. And then people often use their time for increased religious involvement and being able to help out more with the church or volunteer at the temple. And so both religious attendance and practice and beliefs, all of that increase in older adulthood. And this is correlated with higher self-esteem, life satisfaction, overall happiness, and better physical health.